Hello, and welcome to the Neurocritical Care podcast. This is our Perspective series, and I'm your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. In our Perspective series, we've spent a lot of time focusing on some of the founders of our field and reviewing the history of neurocritical care. But today, I'm really excited to share with you the future of neurocritical care. I have 3 current fellows with me. They're going to introduce themselves, and we're going to find out a little bit about what it's like to be training for a career in neurocritical care. Diana, can you get us started by introducing yourself?
Absolutely. Thanks for having us. I'm Diana Alsbrook. I am a second-year fellow at University of Maryland, shock trauma, neurology trained, so did neurology residency and then stroke fellowship, followed by neurocritical care. So excited to be here.
Awesome. Thank you, Diana. Scott, introduce yourself to the people.
Same thing. Thanks for having me. Scott Sparks. I'm turning at Duke University. I'm emergency medicine trained. I'm actually a non-traditional first-year fellow. I practiced for 12 years, and then I came back to fellowship.
Oh, that's awesome. We're definitely going to dive into that in our interview here. And Sonia.
I'm Sonia. I'm a second-year neurocritical care fellow at University of California, Irvine, and I'm neurology trained.
Great. Well, thank you all for joining us. And I think the listeners are really going to find this exciting. I think a lot of us look back at our fellowships as really special times in our careers, but we also forget pretty quickly what it's like to be a fellow. And so I think this will be a good reminder for those who are a little further along in their career, and maybe a good introduction to applicants who are interested in applying in neurocritical care. And so I kind of want to start with that. So all of you at one point were deciding to apply in neurocritical care, and you all kind of came from different backgrounds. What were some of the things that you were looking for in a neurocritical care fellowship? And maybe, Scott, since you came from emergency medicine and had a career as an attending for a while, I'm particularly interested in your answer to this question. So maybe you can kick us off.
Yeah, it was probably that just, life made sense. My kids are mostly grown, and it was a time where I could make a decision that was more for me. And when I was in medical school, I worked on a neuroscience graduate degree, and it was intending to do neurosurgery. But life gets in the way, life changes. But the love for the black box, the brain and spinal cord, and these weird diseases. I love emergency medicine, and I love the acuity. But there was still a part missing, and so my life allowed me to make that change, and I had some good mentors that got me to the program that I'm in now, and it's been great. It's been hard to make the transition back to training. The financial implications certainly are tough as well, but I love every day. I'm tired, but I'm happy with what I'm doing right now.
Excellent. Diana, I see that the tired comment really resonated with you, which I appreciate as your fellowship director. Maybe you can share a little bit about what you were looking for in a fellowship when you were a neurology resident and sort of on this interview trail that's about to start for a lot of people around the country.
Yeah, absolutely. I think something that was important to me was I trained for residency and stroke fellowship, I trained at a very inpatient heavy hospital and program. And one of the things that we didn't see a whole lot was trauma. And so something that was important to me as a neurointensivist was to know how to manage neurotrauma. And so that was one of the things I was looking for, a big neurotrauma hospital with kind of a trauma focus. And then I wanted something that would make me a really good critical care doctor, not just a neurointensivist, but a general intensivist as well. And so, I kind of chose programs based off of that and interviewed. And I think throughout the interview process, you just see kind of who your people are. I say that all the time when I mentor people, residents and med students, like you just kind of find your people. I think neurocritical care is very much like that. You kind of find your people, and then, but the things I was looking for the most was neurotrauma and being the primary fellow in other units that would make me a good overall intensivist.
And Sonia, same question to you.
I think what Diana said really resonates with me. I too value the opportunity to serve as a primary fellow on other services. And so that was an aspect that was important to me. Something that really drew me to my program specifically was what I saw in the attendings as an opportunity for mentorship for me. And I just couldn't pass that up. I really enjoyed speaking with the people of my program, and that drew me in. I think another thing was I was really curious to know if what I would see in fellowship, how it compared to what I saw in residency at a different site or a different location. And so inquiring about some of the neurosurgical side of things, what procedures are they comfortable doing and what monitors are they comfortable with placing, because that obviously interfaces a lot with what I would do on a regular basis.
Great. And now maybe we can sort of help these residents who are about to embark on this interview journey. Sometimes when they interview with us, fellowship directors, they ask us questions and they seem like their entire decision hinges on the answer to this question. And perhaps having a little bit more experience than they do as a fellowship director, I don't always understand why that seems so important to them. Having been in a fellowship for a year or 2 years, are there things that you think maybe people focus too much on, or maybe they should deprioritize in their search for a fellowship? Yeah, Scott, want to take that one?
Okay, so part of it may be generational. I don't want to be the old guy in the group, but
we love old guys.
Okay, so when I trained at VCU for residency, which is in Richmond, Virginia, it's a very high volume inner city trauma center. It was before the workout restrictions, and it was brutal. But I think coming to fellowship, and I think with the hour changes, I think it's observed, everywhere, but I think it's interpreted a little bit differently. But I think from the attending side of it, when I left residency and my ultrasound training the first time, I thought I would be less busy. But I think part of it is life and part of it is being an attending. You are just busy in a different way. So coming back to training, yes, we all know. I mean, I'm only a first year fellow, but I know that Diana, you're second year fellow, so you've already been going into the second year. There are weeks and weeks that we're on service. There are long days. There are not as long days. But I think it's having the big picture that when we're done, we're still going to be busy. It'll just be different. And I think it's just knowing that. But you don't know what you don't know until you've been through training. That, yeah, it was busy, but I've adjusted to the new norm. And then, but your life afterwards, you'll shape it the way that you feel works best. Because I know there are people are scared about how many hours am I going to work? Am I going to have a lifestyle? But at the heart of it, we're still trainees. We're not going to have all the free time.
Yeah, Diana?
Yeah, I would I would echo that. I think we possibly focus too much and not saying it's a bad thing to kind of figure out what your schedule is going to be, but maybe focus too much about making a decision based on what the call schedule is going to be at a place, or how many nights do I have to do, those kind of things. I think I've heard a lot when we sit in these interviews, when residents ask us kind of like, how many nights do you do and things like that. I think nights are when you learn the most sometimes, when you're kind of there and have that autonomy to kind of learn on your own. And the call schedule at the end of the day, like Scott mentioned, you're just kind of busy all the time. And so the call schedule doesn't make that big of a difference. I think it is a huge point of focus that maybe shouldn't be a point of focus. I don't know if Sonia agrees with that or not.
Yeah, I agree with that entirely. The other thing I was going to add was if I had to think back about something I was focused on that didn't end up making a significant difference, I think it was probably bed count. And obviously volume is important, but volume has a lot of dimensions and aspects to it. And so just because one ICU has a different bed count than the one that that doesn't mean that you're going to be twiddling your thumbs by any means. You could have patients on other floors and you're still the primary. If you're co-managing with trauma service and the patient keeps going into ICP crisis, you're going to be at that bedside constantly. So that was something that I didn't have perspective on, and now I do.
No, that's a really good point. All right, so we talked a little bit about kind of helping people try to make fellowship decisions, which I think will be really important as we enter the match season. But let's say after you matched, I'm sure all of you were really looking forward to fellowship. What were you most excited about? Sonia, do you want to take that one?
I think what I was most excited for was gaining confidence in critical care medicine. I obviously loved my neurology residency, and part of my love for so many dimensions of neurology is what led me to neurocritical care. But I was excited to be able to walk into a patient's room who is unstable, hemodynamically unstable, and have different tools in my armamentarium to help get them through it. And so I would say that that was what I looked most forward to. And that's something I'm proud that I've learned over the last 2 years, 1.5.
Awesome. Great answer. Scott, I'm going to flip it on you a little bit. So you were coming from having been attending for over a decade. What were you most worried about going back to fellowship?
It was the fact that I'm not a neurologist. It's been more than humbling. I taught at a couple of academic programs, teaching ER residents and medical students, and ultrasound fellows, but it was humbling. I'm walking into a field I don't know. The folks that are trained as neurologists and neurosurgeons. It was two things. It was to be humbled to step back into a trainee role. It was also to step into a field where I don't know enough. And in the 8 months that I've been a fellow, I've learned a ton. We have primarily neurology trained intensivists, but then we have a smattering of anesthesia, ER, and neurosurgery. And it's been great to learn a brand new field. I don't know if it's just that I get the chance to learn something new. I was excited enough that my program director said, "Here, why don't you read this?" I think Blumenfeld.
Yeah.
There was a lot of reading before fellowship, but it was just that exciting to be able to do that. And Sonia, when you were saying about having those tools, I feel like a much more complete doctor. I know there is a huge gap for emergency medicine trained people, and I think that's what those from my primary training field could bring to it. And I think that if they come in with that same open mind of it is humbling, I do have to literally learn a whole new language and a whole new field.
Yeah, well, as I try to tell all of our fellows, I mean that should be true for every fellow, because if you already knew it, you wouldn't have to do fellowship. Diana, you had some thoughts?
Yeah, I think for me, it kind of to his point, as far as like people ask, I think a lot about how do I prepare? Like that's a question I get a lot when med students are about to start residency or residents are just about to go to fellowship. Like how do I get ready for this? I think the most important thing for me was to become the best neurologist I could be. And kind of, although I like I said, I was at a very heavy inpatient program. And when I got the chance, I did procedures. When I got the chance, I took care of the sickest patients when I was in the unit. But I think becoming really good at your main field, your main specialty is the best way to kind of prepare for critical care. And we all bring something different to the table. I've really enjoyed, we're primary fellow in all the units. So we work with surgical ICU fellows. We on different sides of the unit. We work with trauma ICU and Palm Crit and all the different types of ICU fellows. And so we interact with anesthesia and emergency medicine trained folks all the time, neurosurgery trained ICU folks, surgery trained. And I think everybody brings something different to the table, and it's nice to learn from those kind of different perspectives. And so I think it's really important to remember, even when you know from the beginning of residency that you're going to do neurocritical care, even if you start ER knowing you're going to do neurocritical care or another specialty, that you kind of become the best you can at your kind of general specialty first. And that brings a great perspective.
I think that's great advice. Sonia, I want you to add on to that, but I'm going to throw in another question at you. Okay. And this is kind of getting into this idea that sometimes we attendings forget what it's like to be in the fellow shoes. What is something that you have struggled with or found challenging that maybe your attending on service has just no idea about?
I need
what are our blind
think
spots
about
in terms of the fellow frustrations? Because I think we all have blind spots in terms of kind of getting into the perspective of our trainees.
I think I need a moment to think about.
You can think about that one.
I'm sorry, but I just wanted to add on to what Diana was saying about being the best neurologist that she could. For the PGY2 and PGY3 neuro residents out there who are wondering if Neurocrit is right for them, that may be a sign. To me, neurocritical care distills down all the exciting parts of neurology. You're treating status, you're treating a myasthenic crisis, you're treating, I don't know, really bad ADEM, and then, of course, all the other bread and butter neurocritical care. So if you find that you like the pace of inpatient neurology and you also love more than just stroke, for example, that may be a sign that Neurocrit is for you. Okay, I'm going to think about challenge.
All right. You can think about that one. Scott, do you have an answer for that? What are some of the challenges that fellows may be facing on a day-to-day basis in the ICU that the attendings are perhaps a little bit blind towards?
Probably speed of thought process, because you said if we had already been experts in the field, we wouldn't need the training. So when I think through a complex I have a pituitary macroadenoma that was just resected, and when I have to think through quickly what's going to happen when I give the DDAVP and what do I expect, what part of the triphasic response are we in, that we do have to have that moment to think through, or we actually, especially because I'm early in fellowship, I may not have had a chance to think through it and really understand so that I can treat them really quickly, because that's part of early in training. But for any trainee, we may not have thought through and it's not quick to know what to do and what the complications might be, and then also how to treat those.
Yeah,
that's where I think some of the attendings might be blind to, that we may not have thought through it because we're just not there yet. We don't have the experience.
All right, I love this. Let's dig into this a little bit more. So, because I talk to my attending friends all the time about this. So some of them say, right, that they don't want to do a whole lot of teaching on rounds towards fellows because they don't want to sort of reveal that the fellow doesn't know in front of the larger team, right? They kind of feel like they may be undermining the fellow's authority as an expert or as a teacher if they start directing a lot of teaching at their fellow. And so instead they try to focus mainly on the residents, and knowing that maybe the fellow doesn't know this and hoping that the fellow is sort of catching on that, like, hey, I'm teaching you. But I think sometimes, and I had a lot of that experience when I was a fellow as well, and there were certainly times where I had no idea what was being discussed, and I learned by the attending teaching the fellow. I think sometimes though the fellows walk away from that feeling like there's no teaching for me. I'm not the point of focus here, and there's some dissatisfaction. So how do you feel about kind of direct teaching on rounds towards fellows, and maybe being asked questions to assess your understanding in front of the rounding team? Because that's something that as attendings, I think we all worry about, actually. Diana, do you?
Yeah, I think to your point, teaching during rounds is hard for a lot of reasons. You have like different levels of learners, and I think we talk about this not infrequently, but as part of fellowship teaching as well, like teaching the fellows teaching as well sometimes, and I don't think you have that recognition until you start teaching at the bedside, that like, oh wow, there's way different learners. Right now in service, I have a third-year med student, I have a fourth-year med student, I have a second-year resident, I have a kind of mid-career APP, and those are lots of different types of people. And then, there's the attending, and then there's me. And so, to a certain extent, I think a lot of teaching to fellows is not done on rounds. I think the majority of the teaching that I get from attendings is kind of after rounds, walking the unit with the attendings, just kind of chit-chatting in the workroom about different patients, and kind of that really deep pontification that you can't really do on rounds because you have to get through rounds and take care of sick patients. I think teaching your fellows during rounds can be really hard. I do think it's a balance of like what your comment about kind of undermining the fellow's authority, and you obviously don't want to make the fellow look incompetent during rounds. I think some attendings are better than others about kind of meeting the fellow where they are and kind of asking very directed questions. Our division chief, Dr. Bajadia, he's very infamous at the University of Maryland for asking these very like bizarre, kind of very thoughtful questions that he honestly doesn't even expect you to know, but it's to make you think and to make you go home and be like, man, I really don't want to disappoint Dr. Pachadia tomorrow when he asks me the same question, So I think, I think to me, a lot of the fellow to attending teaching happens in that one-on-one, those deep conversations you have about patients.
That's great. Scott, what have you found to be sort of the best way to kind of facilitate getting as much out of that attending fellow relationship as possible?
I think depending on the attending on service, we'll run the rounds, and then by individual patient, they'll ask us, what is your thought process for, why, whatever drug you're picking or treatment modality or imaging or whatever it is. But then, I think we have a good amount who are willing to, then we would bounce that same question saying, this is what I think based on what I'm seeing at the bedside, on the imaging, the whatever from pre-rounds. And this is what I want to do. And then if it's something that's not straightforward, then they're open to hearing, what is your thought process? Because I don't know if this is going to actually improve the patient or not. And I think that helps because then you have that experienced thought process where they've been through it, and they may also know the literature or how to apply the literature better than we do as trainees.
And Sonia, sort of a similar related question, but any tips for how to get the most out of fellowship from an educational standpoint? I mean, I think one of the real challenges is, I think you all have sort of alluded to the fact that fellowship's tiring, right? It's pretty exhausting. And a lot of times people say things like, well, you need to go home and read. And then if your days are really long and you're really tired, reading can be really hard. So do you have any hints for actually how to learn stuff other than just showing up every day and going through the normal schedule?
Yeah, I'd say some things that I've done are, we obviously have our neurocritical care didactics, and there's the neuro and neurosurgery grand rounds also that I try to attend. But in addition to those, I've gotten to know a lot of the other fellows in MICU and the SICU, and it's a very inclusive culture here, thankfully, and so I can go to their didactics, it basically comes out to, there's a critical care lecture that I can attend every day from all these different services. There's also this ultrasound. The CVICU does a weekly echo practice. They hire a life model to come in, and so I've found that has helped me expand my critical care knowledge base tremendously by seeking out those opportunities. It's a time to catch up with, because also I'm one of 2 fellows total for neurocritical care. So that's like my friend group now is the other critical care fellows. As for other ways to incorporate learning while you're on service, I think that just for me, for maybe my 2 sickest patients, or maybe there's also one mystifying patient that's not necessarily the sickest, I'll try to, after rounds or before I sign out or when I get in the morning and everyone's pre-rounding, I'll just try to look up that one question that I have about that patient, and then podcasts, lastly, this one included.
Hey!
Those are my favorite modes of teaching. I was in charge of designing the curriculum for my residency. It's definitely important to me, and so I'm glad I got this question because I've thought about it a lot.
You are welcome back on the podcast anytime you want. That was a fantastic answer. That's great. I'm wondering if we can switch gears a little bit now and talk about kind of other things that are part of fellowship, maybe that aren't just kind of bedside rounds and patient care. So I think a lot of fellowships have other expectations for fellows, whether that is, triage, whether that is doing some teaching of didactics or being involved in quality improvement or having a scholarly project. And I think to a different extent, this becomes either part of people's career or it sort of drifts by the wayside depending on what their interests are. I guess maybe we'll start with Scott. I'm interested, Duke traditionally is a pretty academic place, and I think attendings are often, quite busy with their other academic pursuits. What are the expectations at Duke for their fellows, and how do you balance that with your clinical responsibilities?
I'm sure it's probably like everybody else. It's just a lot of juggling. The little free time that we have, it's juggling. Yes, Duke is an academic heavy place, but luckily for this program in particular, it's more fluid for what your academic or scholarly project might be. They don't force you into one box. You have to have a research project. It might be, write a book chapter or, teaching, or sure, join our research project and have your cut out focus in it, and then produce something, or go teach at some other university's ultrasound program, and but it is fluid. And that's I'm actually very thankful for that, because my background is ultrasound, so I primarily echo, so I had a chance to teach, and it was great. So but it's juggling, because they also have us doing a local journal club, and so we do it for critical care, and then we are part of the southeastern U.S. And so when we at some point during fellowship, we do have to present a large paper to all the southeastern U.S. Programs at joint. So it's
Do you want to talk a little bit about that? Because I don't think many people recognize that there are fellowships that kind of work together and have joint programs. So what is this? I've heard of this before, because I believe Emory is part of this. Is that right? My friend from Emory was telling me about it.
Yeah, it's actually driven by Emory. So it's Emory, MUSC, Duke, Chapel Hill, Miami. I think maybe UAB. I'm blanking. I can't think of all the programs that I see log in, but we talk about Sahara and some other trials, and we'll break down the papers. One fellow will, with an attending from another program, will break down the paper and get the presentation ready, and then have some thoughtful questions, and then we have a discussion about it. So it's actually cool, because then we can, not that it's kind of like this. We get to interact with people from other programs. We and see their faces, and it makes it friendlier when we do end up seeing them at conferences. I'm sure I haven't seen anybody yet, but it'll make it easier to put a name to a face. And I've seen you while I've asked you questions when you were presenting, or you were the faculty moderator.
No, I think that's very cool. We have something sort of similar in this area for our core critical care curriculum, where we actually share it among, I believe it's 6 hospitals now. It used to be 5, so we called it the DC5, but now there's 6, but we haven't changed the name. And it's just a way to really share core critical care with a large group of people. And since we all meet over Zoom a lot anyway, it seems silly to limit yourself to one institution when you may have a really great teacher expert at another who can share that across institutions. And it certainly helps for faculty, because it's tough to give one talk for my 2 neurocritical care fellows or 4 neurocritical care fellows. It's a lot more fun if you can give a talk and have it discussed among a group of 50 people, right? All right, Diana, I'm wondering if maybe we can kind of shift gears so a little bit more. Diana has really been transformational at University of Maryland for making sure that we attend to this big point of interest in the ACGME right now, which is wellness. And she has planned events both within the ICU and out of the ICU. And I think it's so important, and we're really grateful to her for kind of leading this. But Dana, can you talk a little bit about what is wellness to you in fellowship? Like, what does that mean? Because I think a lot of people, I don't know, it can be such a nebulous term.
Yeah, I agree. I think wellness is different to a lot of people. To me, it just encompasses like how you feel about yourself in that particular moment. And I think, self-care, we throw around this term like self-care and wellness and all of these terms, and all of them are important. I think kind of to demonstrate kind of how much you sometimes forget about that. I was I remember on service not too long ago on a Sunday. I was post call and I was rounding, and I reminded this patient's wife. I said, you gotta go home. You have to take care of yourself. You can't take care of him if you don't take care of yourself. And she kind of looked at me and she was like, I've seen you for the last 7 days. So what are you doing to take care of yourself? And I was like, okay, well, that's
touche.
moving on. Right. So, but it is important. And so I think, different people need to take care of themselves in different ways. And I think by the time you're in your 30s, usually people know what that is. But I think it's also important to note that especially when you're newer in this career, even later in your career, I think you can take the hospital home with you a lot. And, that can be good for learning and stuff, but it can also be really bad for burnout and self-care and kind of wellness. I liken it to like second impact syndrome sometimes, like how we code a patient or a patient's dying and we have this deep family conversation and then you kind of have to move on to the next patient who's also sick. And so I think all of these things are really important to me. Social activities and kind of getting out of the hospital and seeing the people you work with in different settings is really important to me. It's not important to everybody. To me, it's really important because, I spend more time with y'all than I do my own family, right? And so I think that's the case for the majority of fellows. And so it's nice to know like what's going on in your life. What's going on in my life, so that when you look kind of different or you look off or you're having kind of a weird day, that like I know, okay, like that's just something's going on with Nick, maybe I should like ask him about it. And so those kind of things are important to me. A lot of people think of like wellness and self-care as like, oh, I need time off. While that's true, you definitely need to like balance and days off are important and taking care of yourself. I don't think when I talk about wellness, I'm not saying like, oh, we need like weeks off, we need more vacation, we need, less nights or anything like that. It's mostly just a little bit of time to yourself, some socialization with the people you care about, your family, your kids, your spouses, significant others, your friends, and then the people that you work with to kind of build those relationships to where it's not just like I'm going to work and I'm going to see these people and then I'm going to go home. And I think all of that is really important. That was a long-winded answer to
Oh, that was great.
Question.
Sonia, you look like you have some thoughts on this.
I really loved what you were discussing, and I agree. Maybe I guess I could add, when you have a brief respite from being on service, being a little intentional about what you're planning to do with it, whether that's because that you want to do something fun for yourself, or if it's I need to take care of XYZ task to not be stressed about life things during work the following week. And then also if your schedule is in any way flexible, sometimes maybe just asking how much the on-service time can be broken up. So like either being on service for several months at a time or asking if there's any way to break that up just to change workflow and give yourself fresh daily routine. Those are the things I would add for wellness incorporated into fellowship.
Great.
Yeah,
well,
I think.
Oh, sorry. Go ahead, Diana.
I was just gonna follow that. I think like as far as like kind of breaking up the service time, I really like that. I really like, our schedule is kind of broken up into service time like that. We get kind of electives intermixed with ICU time, but we also switch ICUs kind of intermittently, which is also nice. You get kind of a different perspective, a different unit, different people, and it's kind of refreshing. So I certainly agree with that.
Great.
Just add one thing. So I liked what Sonia was saying about the being intentional. I think, a lot of times in training, in residency and fellowship, it's survival mode. You got that one day off or your post call and, you're just I got to wash my laundry. I got to clean my apartment. I got to, go to the grocery store so I have food. But I think being intentional, I'm friends with my stroke fellows and one of the NPs from another hospital. And so one of her phrases is you have to refill your cup. And I think the intentional part is sometimes we have a potluck or sometimes, hey, let's try, but only for a couple hours we'll go and try this wine bar. And even though it might be a school night and I'm on service, I may not go home and read for that hour or two. I may go to the wine bar, it's once in a while. But I think we have to be intentional and refill that cup because it's weeks and weeks on service and it's brutal. And you have to come back and mentally able to do it and be engaged.
That's great. The airway guru, Rich Levitan, he talks a lot about your beauty to death ratio and being very intentional about trying to make sure you actually expose yourself to life and beauty when you're dealing with a lot of death. And I think that's really important. Good advice. Glad you all have come to that conclusion probably long before I did. Along those lines, maybe Sonia, I'll ask this as we sort of wrap up this interview. What are some things you like to do out of the hospital, and any kind of ways? It sounds like you've maybe scheduled time to make sure that you're attending to those hobbies or passions. Is that right?
Outside of the hospital, I think that, well, I became a parent when I started, sort of shortly before I started fellowship. So certainly my free time is filled differently now. And
To say the least, yes.
so yeah, our weekends are usually if it's up to me, I will go seek out a new bakery or cafe and then go to a playground with my son. And those are usually the highlights of my weekend.
We haven't talked about being a parent in fellowship, and I think we would be remiss if we didn't do that. Did you have your child in fellowship, and what's that experience been like, or just before?
Yeah, it was in residency. So I'm so happy to be a parent. It was certainly a bigger undertaking than I could have foreseen, and I've been fortunate to have a very supportive spouse who's also in medicine, and then the support of our respective moms. And so there's also ACGME. Actually, I don't know if it's ACGME, but at my institution, they have a great offer for backup care if my son is sick and he's not allowed to go to daycare, obviously. And so there are some resources that I've come to see that are there for trainees who are also parents, and I'm very grateful for those.
That's excellent. And Scott, it sounds like your kids are older now, is that right?
Yeah, they're in high school.
They're in high school, so you can tell Sonia that there is maybe light at the end of the tunnel.
There is that one. Once they can feed and water themselves, it makes it more bearable. But it's just like, being an attending. It's busy, just different. And you love watching them when they're little and climb on the playground and make sure they don't fall down too much, and they don't choke on something they're eating, and then instead they'll still fall down, they'll still choke on stuff, and they just can find different ways to get themselves into trouble. And
yeah.
But it's maximize your time with them because it goes so fast. I had my kids in one in medical school and one in residency, and it went by fast. And I made sure I spent every moment that I could with them. I made sure I had time for me and my ex-wife, but we made sure we spent every moment that we could, with them reasonably, because that's what they're going to remember. Not that dad was a doctor, not that mom was director of a large education program. It was mom and dad spent time with us. That's what they remember.
Well, I think that's also great, hopefully, for people thinking about applying into neurocritical care, that you two are examples of you can have children during training, and I'm sure it's very, very hard, but it's possible with the right support system. All right. We kind of end these interviews with a couple of these kind of quick hits that we do with, we've done them with, everyone from Alan Roper to Gretchen Brophy and several past presidents of NCS. So I'm going to end that's with you. So you might be some of the first non-past presidents of NCS, but maybe future presidents of NCS to answer these questions. But I'll start with Diana. Diana, what's your passion outside of neurocritical care?
My passion outside of neurocritical care is piano. I'm a classical pianist and have played for decades now, I guess. That makes me feel old. So that's what I do for fun.
And then I'll send the next one to Scott. Now that you've done several specialties, is there any other specialty or subspecialty that you would really like to attempt?
I wouldn't want to tell this to my children because they said that 2 is enough. But I because of my background or my subspecialty is echo. I would love to do cardiology. I love the heart and brain connection, and we all do that every day. But yeah, it would be something in cardiology.
All right, and then Sonia, this is the counter question: what specialty or subspecialty is something you definitely would not want to do? I think we all have that field that just was not for us. What is that for you?
Maybe some of the ones with what has been described to me as the slow burn, where it's like this is more for outpatient specialties, I think, for something like a rheumatologic condition where you have this lab workup, it takes a while for them to come back, and then patient comes back and you see them. I'd say that sort of workflow is not suited to my personality.
I think that goes for many of us in neurocritical care. Maybe we'll snake back around. So Sonia, is there a sound or smell in the ICU that you really like?
I was afraid to get this question. I don't have an answer. I mean, I think we can all think of spells we don't like, but I was trying to focus on sound, and I don't know that there's a sound I am annoyed by. Yeah, I'm sorry, I don't have one. I thought about it though. I promise I tried to come up with an answer.
Okay, Scott, how about you? Is there a sound or smell in the ICU that you hate that you just can't stand?
Oh, I don't know about smell because coming from the ER, that's that's it's pervasive of any kind of bodily fluid. But it is the monitors. For God's sakes, you just sit there all night on call, and you have to respond to the messages on Epic or the pager, and then there's the monitors behind you, and it's like, oh God, give me a 5 minutes without something dinging.
Understood. And Diana, I think you're going to finish out our interview here. What advice would you give to the resident applying into neurocritical care?
So much advice. I think that my biggest piece of advice is always just get involved in and this goes for any subspecialty, get involved in the kind of subspecialty societies that you can get involved in. And so for neurocritical care, it would be Neurocritical Care Society or other critical care societies. I think it's really important, not even necessarily for the education, but I mean, just the networking and kind of mentoring alone from some of these societies can be really good and kind of get your foot in the door. Neurocritical care is a very small field, and it's the people are important. And I think no matter what like advice I give to people, it always comes back to the people. The people are what make the fellowship. The people are what make your life and career down the road. And so I think that would be my biggest piece of advice. And then, like I said before, just focus on in residency becoming a good neurologist or a good emergency medicine doctor, a good anesthesiologist.
Great. And because I just can't help myself to have three really smart and aspiring neurointensivists who are going to do great things, what can we as fellowship directors do to make your training better? Nothing. Silence. It's perfect. Oh,
it's perfect. So I think Diana actually said it, or maybe Sonia, you said it, was bringing it to where the fellow is.
Yeah.
I think it's important. For me, I'm a visual learner, so I have to read it. So when the attending understands that, what we can talk through the problem, and if I understand, and if I already know the topic we can talk through it. But then saying, you want to know more about EEG and Hirsch in this one chapter. We're going to focus on this, and we'll review these EEGs after you've gone over it. I think meet us where we are, and that will go far.
That's great advice, Dan. I could see you wanted to say something.
No, I think being being a fellowship director has to be hard. It has to be hard. We talk about. I think listening to the fellows would be my biggest advice. I think every 6 months or every so often kind of meeting with all the fellows and saying, okay, what's going well? What is going wrong? Like, is there an issue with this rotation? Is there an issue with this rotation? What are we thinking? With the understanding of, and I think I've said this a lot, and me and my co-fellows talk about this a lot, sometimes that's just a chance for the fellows to just debrief and vent. And sometimes that will give you like actual useful feedback for things to change. We certainly recognize that like every fellow is different, and certainly every fellow class is going to be different. And I think Nick, this more than just as much as anybody. Like you're going to get different feedback from year to year, and you're like, God, I just changed that. Should I think? But I think listening to the fellows, even if no changes need to be made, I think just listening and hearing us out as adult to adult, colleague to colleague, as opposed to like fellow to attending. This colleague to colleague relationship is really important in kind of involving us as colleagues, and so that involves feedback. That involves participation in things like faculty meetings where we discuss kind of unit issues and unit changes. All of that is really important to fellows as we kind of progress to attending hood.
Yeah, no, that's great. And I think we've laughed about this, but sometimes when I meet with Diana and her co-fellows, I will ask them for some feedback on something, and I could not get like two more diametrically opposed responses. And then the idea that we're going to structure things that's going to fit both of these people is always the challenge, right? And but that is
Yeah.
our job,
Yeah.
is like meet the fellow where they are. And so as much as we can, we try to kind of have the flexibility to meet the fellow where they are. This has been wonderful. I hope that aspiring fellows will listen to this. I hope that there's attendings out there listening to this and kind of maybe gaining some insight a little bit into what it is like to be a fellow these days, because I think it's changed a lot. I can tell you the idea that there is a critical care didactic every day of the week, or that you can be joining fellows from multiple different institutions, or that your epic follows you home. These are actually fairly new developments in the life of a fellow, and many of your attendings have never experienced all of this, these distractions and these burdens in terms of kind of separating yourself from work. So I think hopefully this is really important and insightful for them to hear. So thanks so much for joining us. I am Nick Morris. This is the Neurocritical Care Society podcast. Please like and subscribe, and CME are available for select episodes. You can find our podcasts on the Neurocritical Care Society website or anywhere you get your podcasts. Take care.